Okay, well, good evening, everyone, and thank you for joining us for tonight's webinar, Complex Regional Pain Syndrome Treatments, What's New? CRPS remains one of the most complex and often misunderstood pain syndromes in medicine, making education and collaboration across specialties more important than ever. I'm honored to have one of the leading voices in pain management with us. Double board certified in anesthesiology and pain fellowship trained from the Mayo Clinic. He serves as the chairman of post-surgical pain and holds faculty appointments at several leading medical schools. Dr. Kalava is also passionate multidisciplinary care. He'll be walking us through the latest diagnostic criteria, red flags, and emerging treatments for CRPS, followed by a Q&A. Please join me in welcoming Dr. Arun Kalava.
Thank you, Nick, for the introduction. There was some choppy voice initially, but hopefully the connection is going to get better. I'm going to share my screen so I can put the PowerPoint here. So welcome, everybody. I'm hoping you can see this PowerPoint. I understand the audience here are physicians, physician assistants, nurse practitioners, nurses, and patients as well. So this is primarily for medical professionals, but patients were welcome to join this so they can understand what is new in the world of treatment when it comes to complex regional pain syndrome. These are my conflicts of interest. Today's agenda will be talking briefly about background, diagnosis of CRPS, non-invasive treatments, medications, minimally invasive treatments, invasive treatments, and we'll actually go through a lot of real-life cases. So the CRPS was first described by the father of modern surgery, Ambroise Paré. He actually successfully treated French King Charles IX, who developed apparently CRPS after bloodletting or phlebotomy. In those days, in the 1600s, bloodletting was a common procedure done for most of the diseases. During the Civil War, the term causalgia was introduced. And later in 1946, James Evans suspected this complex regional pain syndrome to be sympathetically mediated pain, and thus coined the term reflex sympathetic dystrophy. So a lot of people know this as RSD. In 1994, the International Association for the Study of Pain named this condition as complex regional pain syndrome. So you can see it's more than 30 years since the CRPS actual definition was defined by IASB. In 2010, the Budapest criteria for diagnosis of CRPS was established. When a patient comes to me and there is a high index of suspicion for CRPS, I usually print out this Budapest criteria or put it on an iPad, and we both sit down and go one step at a time, figuring out whether this particular person has or does not have CRPS. As you can see, we categorize these on sensory, vasomotor, pseudomotor edema, and motor atrophic changes. And based on the criteria that's mentioned here, we will either diagnose or say they do not have CRPS. There is a duck here. Well, if it looks like a duck and quacks like a duck, it is a duck. So if you have a higher index of suspicion, please diagnose CRPS, because the diagnosis is the key step that gets missed in a lot of these cases. So early diagnosis is key. If you feel like or think like it is CRPS, maybe it is CRPS, and you should probably, I would rather overdiagnose than underdiagnose CRPS. There is a multiple classification of what CRPS types are out there. Based on the nerve injury, there's type 1 with no identifiable nerve injury. Type 2 is when there is an identifiable nerve injury. clinically, both type 1 and type 2 are mostly undistinguishable. On the basis of temperature, we have a warm type, obviously it's warm edematous, cold type, which is very cold, blue at times, and less edematous. On the basis of etiology, as I mentioned, RSD was initially introduced saying it's a sympathetically mediated problem, but there is a lot of CRPS out there which is actually non-sympathetically mediated. On the basis of the duration, you can classify it as acute CRPS if it's less than 3 months, and chronic CRPS if it's more than 3 months. Pathophysiology. I could go and talk about this arrows and the etiology, but the number one reason why somebody has CRPS is primarily inflammation. It's either acute or chronic. So remember inflammation. Also, moving forward in these slides, if you see a red notation, that is something that you want to really remember. Also, that's something new that we're talking about. So what is the prevalence? As we already know, females have a higher chance of getting CRPS. 2/3 of them are female. And the average age is about 43 years. Apparently, if you're left-hand dominant, there is a higher risk. This is the unfortunate part. As I was mentioning earlier, the average time to diagnose is 6 months. That's late. It's already a chronic CRPS. We want to catch it when it's acute. And sometimes up to 129 months. That's really, really late, 10 years after. So I will dive into the treatments because that's the main presentation part today. So these are the treatments we already know about: the physical therapy, mirror therapy. Now laser therapy is new. We'll talk about that. Scrambler therapy is new. Magnetic peripheral nerve stimulation is new, also known as axon therapy. As you already know, there's cognitive behavioral therapy and greater exposure therapy, which have been used in the past. So non-invasive therapy, laser. This was a study out in 2025 wherein they used high-intensity laser therapy along with mirror therapy in patients. They did 6 treatment sessions. Pain was significantly alleviated just following the 3rd treatment session. And electromyography actually showed improvement in patients with CRPS. So this is the first trial which was a randomized control trial, which showed promising results for high-intensity laser therapy, which is non-invasive. Again, laser machines are available with chiropractors, physicians' offices, physical therapy offices. So something that's easily available, very cheap, inexpensive to have it done. Scrambler therapy. Now, scrambler therapy uses electrical stimulation to interrupt the pain signals. Now, there's a few case reports, as you can see here, and case series that were published in 2016 and 2023, and I personally know 1 or 2 patients who had tried scrambler therapy and were successful in managing their complex regional pain syndrome symptoms and signs. So again, if it's sympathetically mediated, scrambler therapy should not be helpful. But guess what? CRPS is non-sympathetically mediated, which means peripheral nerves, as you can see in this image, the nerve signals that are being sensed can be interrupted by electricity. Now, using the same technology, instead of using electricity, you can use magnetic waves to interrupt. Now, there has not been a case report or a case series on magnetic peripheral nerve stimulation because it's a very new modality. It does the same thing as a TENS unit or a scrambler therapy does. It interrupts the pain signals in the peripheral nerves. The only positive study we have is the study out by Dr. Better, wherein they looked at 24 patients who had neuropathic post-traumatic or post-operative pain and followed for 3 months. 2/3 of the patients deemed responders showed 87% reduction in pain. It was very significant. And they also saw close to 60% of the patients having opioid reduction. So we have not tested. I've tried a couple of patients with the magnetic PNS, but they tend to be very sensitive to these magnetic impulses. So they need very low energy. And the one patient we tried was not able to tolerate, so we had to stop. Medications are, again, our mainstay in complex regional pain syndrome. You already know about the amitriptyline Cymbalta, pregabalin, gabapentin, bisphosphonates, calcitonin. There's currently a randomized controlled trial going on IV immunoglobulin. The newer medications, again, low-dose naltrexone is something to keep in mind. A lot of people know about IV ketamine, but very few people know about oral form of IV ketamine. Now, you will ask me, why do I have this mushroom? When somebody has CRPS, we know scientifically that there is mushrooming of the NMDA receptors, which is what the ketamine acts on. So they will have many receptors that mushroom, and NMDA receptor antagonists like ketamine that's why very effective. So if you know about IV ketamine, maybe you should look into oral ketamine and ask your physicians, or physicians maybe look for a pharmacy which can supply you oral ketamine. Now, there's other medications, tadalafil, Cialis, we'll talk about that. Oral N-acetylcysteine, vitamin C. There are a few studies which show that it can be prophylactic in patients who are getting surgeries. Topical DMSO can be effective in warm-type CRPS. Lidocaine patches, oral corticosteroids. One thing that's also new is Suboxone, a medication that's commonly used in patients with opioid addiction. Oral corticosteroids. Now, this is probably the most important development in the recent past, wherein studies out from Canada showed a robust and effective outcomes. So if you look at this patient's foot, this is an image from Dr. Paul Winston, foot before and after. If you see the temperature difference was significant, drop by more than 1 degree Celsius after a month of prednisone. So this was a study that looked at the retrospective analysis of 39 patients, 100% resolution in 19 patients. We have not heard a cure for CRPS, but we actually have a cure for CRPS if it's diagnosed early and treated early. So the other 19 had partial resolution, only one did not respond. That's very promising. So if you're in acute stage of CRPS, or if you're a physician looking at a potential CRPS, please initiate them on steroids. Be mindful that they're high dose. Be mindful in patients with adrenal insufficiencies and diabetes. Low-dose naltrexone. Again, this was a study, a little case series that was published in 2013, wherein they treated the CRPS, 3 cases, both symptoms and dystonia. And what is LDN? Well, naltrexone is a medicine used to treat opioid addiction. And at a low dose, it tends to be a very good analgesic, especially in patients with fibromyalgia, chronic pain syndromes, and even CRPS. So LDN is known to antagonize toll-like receptor 4 pathways and attenuate microglia. Now, what is microglia? Well, they are just, resident immune cells that come into play when somebody has injury or disease. Obviously, we had an injury or disease, which ended up being CRPS. In these 3 patients, prominent CRPS symptoms remitted in 2 of them, completely remitted, including dystonic spasms and fixed dystonia. The dose that we usually use for a low-dose naltrexone is about 1.5 milligrams to 9 milligrams once daily. It's very well tolerated in most patients. Once a night dose lets them sleep better, pain's better. Now, tadalafil was FDA approved for erectile dysfunction. You'd be like, oh, we did not know that. Well, Cialis was actually studied in an RCT, or a randomized control trial, wherein they looked at blood flow, pain, and function in cold type CRPS. 24 patients received 20 milligrams of Cialis daily for 12 weeks. And they found that tadalafil, Cialis, actually reduced pain and improved function in these patients clinically and symptomatically. Suboxone, again, another addiction treatment drug, which when used a transdermal route could be helpful in patients with CRPS. This was reported 2 cases with refractory CRPS, and they had 50% reduction in pain intensity scores. Obviously, as I mentioned earlier, it's an opioid addiction treatment. Now, if you look at this mechanism of action, well, it acts on the NMDA receptor. So guess why somebody should consider Suboxone if they have CRPS? Because it does act on NMDA receptor, as does ketamine. Now, we finished the non-invasive treatments. We finished the medications. We'll talk about minimally invasive treatments. Peripheral nerve blocks and catheters. Sympathetic nerve blocks. A lot of people know about stellate ganglion blocks and lumbar sympathetic blocks as potential treatments because we've been taught that CRPS is predominantly sympathetically mediated. I tend to disagree heavily on that aspect, saying it is predominantly non-sympathetic and to some extent sympathetically mediated. And that's why this presentation is important. We also will talk about cryoneurolysis, percutaneous peripheral nerve stimulation. So peripheral nerve blocks and catheters. Again, we talked about CRPS being more common in the extremities, the upper extremities and lower extremities. Now, every upper extremity, you can find different nerves, you can isolate nerves, and then do a nerve block to interrupt the pain signals. This was the few case reports out here. 16-year-old man developed CRPS after injuring his leg playing basketball. Peripheral nerve blocks was performed 6 days after injury with complete resolution. Again, we're actually seeing resolution, complete disappearance of pain and symptoms with treatments like prednisone, nerve blocks, nerve catheters. This is an image of a sciatic nerve catheter with a ball of local anesthetic. This patient of mine had CRPS of the ankle. We sent her home with 7 days of this medication. Hers did not completely resolve, but she had significant improvement in her symptoms. Doing these peripheral nerve blocks requires ultrasound guidance, so please be mindful to be precise when doing these procedures. Cryoneurolysis. What is cryoneurolysis? Well, we're using cold in achieving what we need to achieve by interrupting the pain signals from being sensed by the patient. As I mentioned, it's a non-sympathetically mediated condition. It is not it's heavily sympathetically mediated process. So believe me. So Dr. Filipowski in Denmark, published these multiple cases of CRPS where he treated upper extremity and lower extremity CRPS with cryoneurolysis, just freezing the nerve, that peripheral nerve that needs to be targeted. They usually do a diagnostic block. If the patient gets temporary relief, you go ahead and freeze that nerve for long-term relief. What it does is it interrupts the pain signals. They also described a case report in 2021 wherein they did the cryoneurolysis of the stellate ganglion so the patient would get long-term relief. Peripheral nerve stimulation. This is the best part of this webinar today. This is the only study I know which has more patients with CRPS that were taken into consideration than any others to prove efficacy of a certain modality. 169 patients over 30 years. A lot of these peripheral nerve stimulation implants were done surgically because we did not have that technology 10, 20, 30 years ago. Now we can do them percutaneously when the patients are awake with no downtime. If you look at 12 months pain scores, they were better. Function of 51% improved, reported improvement. There were some of them who actually reported worsening. I was wondering if the disease progressed or they had multiple nerves which needed to be targeted. 36 patients who continued to follow up, 81% continued to use their nerve stimulator. This is just an example of how many more case reports are there. Again, each patient is pretty much a case report in CRPS. Not everybody responds to the same treatment. Everybody needs a different treatment algorithm to be followed. Invasive treatments. I'm sure physicians you see might have recommended a spinal cord stimulator. or physician would say, let's do a dorsal root ganglion stimulation. DRG is only approved for lower extremity, not upper extremity. So if you have upper extremity CRPS, then you might be offered SES. If you have dystonia or spasticity, then intrathecal pumps or spinal pumps with baclofen are offered. I have an image of a tree. There's a reason why. These invasive treatments are invasive, number one. They go and stimulate the spinal cord and to some extent the thicker branches. But in CRPS, a lot of the times, the peripheral branches is where the problem is. Why would I treat the tree trunk when I have a problem in the small branch? That's where peripheral nerve stimulation has more efficacy than treating the trunk. So if somebody offers you these, patient, you might want to talk and look into this. Why am I stimulating the tree trunk when my problem is at the peripheral branch? All right, a lot of science, right? But show me the money. Okay, let's talk about real life cases. Patient 1. She's 58, right-handed, present 6 weeks after distal radius fracture surgery. That means she had broken wrist. Symptoms include tingling, burning, swelling, sensitivity to heat and cold, discoloration. She's tried physical therapy, low-dose prednisone, did not help, so she comes sees me. I put her on prednisone for a month, ketamine, laser therapy, locally because she was far from our office. This is a video of her. And she was discharged from my care. Second patient, now we're getting into longer duration diagnosing these patients. 4 months, 48 female, right-handed, same thing, distal radius ulnar fracture surgery. She surprisingly had no resting pain, a lot of swelling, stiffness, and discoloration. I said, maybe this is more sympathetically mediated and I should try a stellar ganglion block. She has tried physical therapy, gabapentin, nothing seemed to have worked so far. We did a left stellar ganglion block, prednisone for a month. She had 10 sessions of laser and she went on oral ketamine. This is her video. Play it again. It's very impressive how these patients come and how therapies can make a difference. She was discharged from my care 2 months after, so she was a happy camp. Now comes 6 months. Actually, it's a man, 54. He's diabetic, right-handed. This was left-handed CRPS. This was the image that he showed me that he had an amputation for necrotizing fasciitis. That was 6 months ago. Pain is a 15 on 10. He's been to multiple ERs with no help. As a screwdriver being bored into his hand, he cannot move his fingers. He's tried gabapentin 3 times a day, 2 stellar ganglion blocks with no effect. First visit, I said, okay, I think like it is more a non-sympathetically mediated pain syndrome. Let's try a brachial plexus block with long-acting bupivacaine. Immediately, he's able to move his fingers and his pain gets reduced by 50%. I prescribe prednisone as usual and start him on oral ketamine. He sees me 10 days later saying, I have mild improvement. And I asked, did you start your prednisone? Well, he said, well, the pharmacy dispensed me Medrol dose pack, which is a tapered steroid dose of 24 milligrams to 4 milligrams in 6 days. He actually ended up in the ER due to high sugars, though being cautioned that you need to be checking your sugars. He said he saw another pain doctor who suggested he should get a cervical spinal cord stimulator. I said, we haven't done anything. You should not be going for a procedure that's very invasive. 19 days later, he comes back. He says he was in the ER because of left shoulder pain and he was unable to move his shoulder, and the MRI showed cervical spinal stenosis. He was at that point willing to try IV ketamine, as the oral ketamine effect was short-lived. He liked it. Then we said, okay, let's start the infusion, and we did 5 infusions of 80 to 150 milligrams, so 60 to 90 minutes. 5 weeks later, he comes with his wife, and the wife says he attempted suicide by taking insulin, and he was hospitalized. And by then, he only had 1 week of prednisone. And in the hospital, one of the doctors prescribed him Suboxone, and he said he got 50% relief. He came back and said, I would like to continue my oral ketamine because it does help me, and will restart prednisone. At that point, we have not seen him. It's only been a couple of weeks since we last saw him. So here, the moral study is, it's a suicide disease in some of these patients. It's very difficult to manage, and they go through a lot of ups and downs, a lot of treatment options being thrown at. In this particular patient, ketamine worked, nerve block worked, Suboxone worked. The steroids we could not get him to take for different reasons. This is his hand, before and after. This is after ketamine. He's able to move his fingers, his color is better. This was just after 1 infusion. So at 5, he was so ecstatic, but it was short-lived. We'll talk about the 4th patient now. The duration's increasing, as you can see. It's 11 months. She's 35, right-handed. Developed CRPS after IV infiltration during abdominal surgery. Pain is 9 on 10, constant. And she's unable to use her hand. She's right-handed dominant, right? She's tried physical therapy, medications, TENS unit, nothing seems to work. First visit, I said, let's try ketamine. Then we did superficial radial median nerve blocks with local anesthetic and steroid, which showed instant 50% improvement in pain and ability to make a full fist. I suggested her that she should do laser. Subsequent visit, we did a stellar ganglion block, which was very short-lived. We prescribed prednisone. Again, it's almost 11 months as chronic CRPS. She was not able to tolerate. Pain actually got worse. Again, prednisone works in majority of the patients if they're acute, but if you see at this patient, it did not help her. It got things worse. We repeated the nerve blocks with a long-acting bupivacaine, which gave her 2 days of relief. After a long discussion, I suggested that she should try peripheral nerve stimulation, but her medical insurance denied coverage. So, smart enough, what she did was she went on GoFundMe and got the money required to have a peripheral nerve stimulator implanted. So I performed a radial peripheral nerve stimulator implantation in the office. She was awake, had it done. Currently, she gets more than 50% relief, but remember, she has another nerve which we have not targeted, and she's happy with ketamine orally as needed, and she applied for disability. Now we're going longer, 3 years. This patient is a man, right-handed. He had a calcaneus Achilles tendon surgery and had a sciatic nerve block for the surgery. His pain was constant, 8 on 10, shock-like, involving both top and bottom of the foot, and most severe between the first and second toes. He's had tried Lyrica, gabapentin, tramadol, Tylenol, Cymbalta, lumbar sympathetic blocks ×4. First one gave 1 day of relief, others gave 0% relief. You see the pattern? He's tried everything, but he has not done steroids. He has not done laser. He's not done ketamine. I said, okay, let's start him on ketamine. We'll do a superficial peroneal, deep peroneal, and tibial nerve block to cover the top and bottom of the foot with local anesthetic and steroids. So he had significant sustained relief at the bottom, but the top of the foot was only temporary relief. For that reason, I said, I'm going to repeat the superficial peroneal, deep peroneal nerve block with steroid again and see if it maybe lasts longer. He got 100% relief, but it was non-sustained. Given his situation, I said, we have case series and evidence that cryoneurolysis is a safe procedure to do. We should consider that. So he agreed to that, and we did a cryoneurolysis. As you can see in this picture, the ice ball on the ultrasound machine and his foot. An ultrasound-guided cryoneurolysis, superficial peroneal nerve and deep peroneal nerve. He gets 100% relief. Again, my point, CRPS is not sympathetically mediated. It's predominantly non-sympathetically mediated. So please change the way you think about CRPS. Patient number 6, a female, right-handed. She had carpal tunnel surgery and cyst removal and axillary brachial plexus block during surgery. Pain is throbbing, aching, hands feel like on fire. She had a stellar ganglion block elsewhere, which gave 6 months of relief. But she was like, I want to try something new. I said, well, it's been 11 years. I'm not going to change what's going to be happening now. Let's try ketamine. She was happy with it. She gets 1 to 2 hours of relief. And then 10 days later, she comes and says, well, my pain is back really bad. Maybe I should get the stellar ganglion block. So we do that, and she gets 70% relief for 5 months. And she came back a few weeks ago to get a repeat stellar ganglion block. She does continue to use ketamine as needed basis. So again, is CRPS sympathetically mediated? Yes. Is all CRPS sympathetically mediated? Absolutely no. So here's a stellar ganglion block. Here's preferably done on ultrasound guidance. Patient number 7. Now the duration keeps increasing. 16 years after she was diagnosed, she sees me. She's 51. Onset after foot surgery. She had 2 spinal cord stimulators. One was a paddle lead, so they actually operated to put this spinal cord stimulator in Atlanta. She says she gets mild to moderate relief, and she wants to try IV ketamine because she heard one of her friends tell her that. I said, okay, we'll try IV ketamine and oral ketamine, and she actually gets significant relief. On exam, we know dystonia and spasticity in her leg and foot. She wants to have the SCS removed now that she was benefiting from IV ketamine and oral ketamine because it's now working for her, and then there are 2 of them in the back. But her main issue seems to be her ability to walk because of the dystonic and the spastic leg and foot. If you can see how her foot is turned around, again, you're looking at 16 years of this. So we did diagnostic blocks of intramuscular branches to the gastrocnemius and soleus, along with tibialis posterior. Her leg is foot. She cries and said, "This in 16 years, I have never seen my foot flat and straight." This was recently, so we scheduled her for cryoneuralysis of these muscles so she can get pain relief and also get her function back. And she's planning on getting her spinal cord stimulators. Remember, I told you about the tree. Don't stimulate the trunk of the tree. It's not necessary. Patient number 8. Now we're going a little too long, 30 years. She's 47. At 17, when she was sitting on a wall, an automobile crushed her left leg. If you look at her right and left leg, you can see how different they are. She's had 24 surgeries so far. She had lumbar sympathetic blocks, same thing, the old school type of doing sympathetic blocks for CRPS. Partial relief that lasted 2 weeks. She also gets opioid tramadol with minimal relief. And unfortunately, she has needle phobia. So we sat down, had a conversation saying, you know, this is new technology. This was 2021. This was 4 years ago. Let's do a sciatic nerve block and see what happens. She gets 90% relief of pain. Again, non-sympathetically mediated somatic nerve pain. We do a trial of the peripheral nerve stimulator. She gets 80% relief. We do a dual lead peripheral nerve stimulator. Here's the femur, and the back of the femur, you see 2 electrodes right next to the sciatic nerve. This was an ultrasound-guided procedure. We took this image after to see where the leads were. She was happy, got 90% relief. 2 years later, she comes and says, "Hey, I have pain in the top of the foot, and I don't want any injections. Do you have any other option?" I said, "I mean, I've heard some of the patients got relief with naltrexone. You want to try it?" She's like, and she tries and she gets 100% relief. So she's out of my care. She sees me once in 6 months, gets a refill for her naltrexone. She's happy. So peripheral nerve stimulation, naltrexone works. In summary, if it's a duct, if it's CRPS, it is CRPS. Please diagnose it early. Understand there's ketamine is very important because there is mushrooming of the NMDA receptors and there is inflammation. Please do not stimulate the trunk much. Treat early, avoid spinal procedures until the last. This is old school, getting spinal cord stimulators. This is new school. Use ultrasound to do your peripheral nerve stuff. Well, how do I learn this? Well, we do have workshops that you can attend. And you can go to ultrasoundexperts.org to register. We have cryoneuralysis workshops, one in Tampa and one in San Diego coming up, so you can register for those. In summary, it's non-sympathetically mediated. Oral ketamine is great. Prednisone is great. Peripheral nerve blocks are great. Cryoneuralysis. Peripheral nerve stimulation wins the contest today. Sympathetic nerve blocks, so-so. Laser is good. All of the medications. Spinal cord stimulation, DRG, usually last resort. I want you to welcome to join the American Society for Post-Surgical Pain, where we talk about these things. We want to further the science of post-surgical pain. Please join us. And we have an annual conference coming up in Tampa this December on 6th and 7th. I'll be there. I hope you come join us. Here are X handles that you can follow me and the society. I thank you for your time. Any questions, I'll be happy to answer.
We do have a couple of questions queued up in the Q&A. If you're able to see those,
Let me just go there.
If not, I can read them off to you.
1 second. I'm just going to pull them up. Sorry. Q&A. Okay. Regard question 1. Okay. Thank you. The patient cases are very important. Thank you. I wonder how you decide which treatment. One of the questions is the patient cases are very informative. Thank you. I wonder how you decide which treatment modality to try on which patient. I think the treatment modality is primarily dependent on whether it's an acute presentation or a chronic presentation. Acute, I would, try to use prednisone, maybe try nerve blocks if the pain is unbearable, so they can get immediate relief. If it's chronic, I tend to certainly start on with nerve blocks and attempt cryoneurolysis or peripheral nerve stimulation. Very good question. Is the time cutoff after beginning of CRPS when you say it is late to give oral steroids? I don't think it's late to give oral steroids depending on the presentation, but if they're 15 years out, I doubt if that would be beneficial, but we don't know until we try. So it's risk versus benefit analysis. If you feel like the benefit outweighs the risk, there's nothing wrong in giving a month of steroids. Maybe that's what they need, and that's what they needed for 15 years. So go ahead and try that. It's the cheapest and the most effective option out there, other than medications and interventions. I guess there's no more questions. Let's see. Oh, there is some. What ultrasound would you recommend to get? I mean, I don't want to be biased. I use the sonocyte. Whatever ultrasound is what you like is what I would say recommend getting. Please comment and use the sympathetic blocks. As I was mentioning throughout the presentation, sympathetic blocks are an option, but they are not the only option available. I would suggest you try non-sympathetic peripheral sensory and motor nerve blocks, and not just rely on sympathetic nerve blocks. They should be considered, but not as the only option for CRPS, because CRPS is non-sympathetically mediated predominantly. It is not sympathetically mediated only. For ketamine, is one round of ketamine enough, or do you prefer continuation with oral as well? Good question. A round of ketamine gives them a boost, and they most likely will need continuing IV oral ketamine therapy or other modalities to give them long-term pain relief. So that would be the answer for that.
Dr. Club, if you want to kill the screen share, we can probably see just a little bit better.
Sure. What do you want me to do here?
Oh, just if you turned off the screen share.
Oh, I see. Okay, stop sharing. Okay. What is your recommendation for an acute case patient located in Lawson? Do you have an office in LA? Any recommendations? I practice out of Tampa. So, I mean, I've given you information. A pain physician might be a good stop. There are big university centers which you can go visit, or you can do telehealth with one of these physicians who specialize in CRPS. I don't have any specific recommendations in LA, I'm sorry. Next question, how do you avoid too much motor blocker when doing nerve blocks or cryoneurolysis? Very good question. Again, the motor blockade depends whether you're using a high concentration or a low concentration of local anesthetic. So a lower concentration would minimize motor blockade. And cryoneurolysis is a very safe, 100% reversible procedure wherein it takes most of the time a sensory part of the nerve out and very little motor. So it is safe enough depending on the nerve. So there's so many nerves. That's why I said this is something very new. A workshop or more reading and more learning on cryoneurolysis might give you a better idea. But consulting a physician who specializes in cryoneurolysis might give you a better idea, because I can't just answer how to avoid. It just depends on the nerve. So if I'm worried about motor blockade, I would just choose peripheral nerve stimulation, because there would be no motor blockade in those particular nerves. Same thing, the recommendations of docs. Do you see loss of dysesthesia after cryo? Loss of this. So even if you see, there is certainly an incidence of dysesthesias after cryo. A diagnostic block should give us a better idea how the cryo should be. It's just a simulation. A diagnostic block gives us a simulation of how the cryo would feel like. Even if there is any loss of sensation or dysesthesias, we expect them to resolve as the nerve regrows. Can you please speak further on the laser you use? I use a class 4 laser. Class 4 lasers are very common in the United States. As I said, they're available in physical therapy offices, chiropractors, physicians' offices. So just ask for a class 4 laser, which is specific for pain. What is the experience with just hydrodissection offsetting CRPS? Hydrodissection is indicated if I have an EMG or electromyogram nerve conduction study evidence of nerve compression, then I would use hydrodissection. Hydrodissection is a very reliable tool if somebody has CRPS because of compression neuropathy. I think we've answered quite a few questions, Nick. We're going to call it a day. People have to go back to their lives and families. We appreciate your time. There is a lot of conversation to have. I think the best way is to join the society, continue the conversation, do workshops to advance your skills, and keep looking for updates as we'll be doing more webinars on post-surgical pain and CRPS alike.